Now we are going to talk about the specific subtypes of non-Hodgkin lymphoma. The most common lymphomas are listed here. On the left side, the B-cell lymphoma, which include the diffuse large B-cell lymphoma, follicular lymphoma, malt lymphoma, mantle cell lymphoma, high-grade B-cell lymphoma with translocation of MYC and BCL2 or BCL6. On the right side is the T-cell lymphoma, including peripheral T-cell lymphoma nonspecific, angioimmunoblastic T-cell lymphoma, anaplastic large cell lymphoma, enteropathy-associated T-cell lymphoma, and so on. Now, I would like to introduce some specific subtypes of the non-Hodgkin lymphoma. First, diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma is aggressive, but some curable. Typical immunophenotype is CD20 positive, CD10 positive, CD45 positive, CD3 negative. 10 to 20% are limited to a single node or extra node site, such as bone, Warthier ring, thyroid, lacrimal glands, or the gastrointestinal tract. CD20 monoclonal antibody, rituximab, significantly increased in efficacy. The large B-cell lymphoma patient frequently presents with one or more rapidly developing tumor masses involving nodal or extranodal sites. The typical large cell tumor mass shows complete effacement of normal lymphoid architecture with a diffuse infiltrate of large lymphocytes. The large cells display more morphological diversity. The variants described as centroblastic, immunoblastic, plasmablastic, and large anaplastic. Many of these lymphomas have chromosomal rearrangements that involve BCL6, either alone or in combination with involvement of BCL2 and in some cases c-MYC. In addition, mutations of the p53 tumor suppressor gene are seen, which have a strong impact on prognosis. This complex genetic background may explain the clinical heterogeneity that characterizes this disease. Diffuse large B-cell lymphomas have some rare, though unique, presentations. Mediastinal B-cell lymphoma is a tumor arising from systemic medullary B cells and accounts for more than 2% of non-Hodgkin cases. It usually presents in a young adult woman as a buccal mediastinal mass with superior Weir-Caval syndrome. The infiltration of the pleura, pericardium, lungs, and chest wall. Diagnosis is based on direct biopsy of the mediastinal mass. Since most of the patients present without involvement of extra mediastinal sites, on histology, the tumor is characterized by a diffuse infiltrate of large cells with clear cytoplasm and some sclerosis. The most frequent karyotypic abnormalities are 9p+, 2p+, and XXY. The 9p24 gain affects the JAK2 locus, despite an aggressive presentation and cause. The outcome seems to be better when compared with other DLBCL. Intravascular lymphoma is a rare presentation of large B-cell non-Hodgkin lymphoma, in which the tumor cells are found within the vascular lumen. This affects elderly patients with an aggressive course and short survival. Primary infusion lymphoma is a rare B-cell variant observed in HIV patients. Primary cutaneous B-cell lymphomas include follicular center cell, marginal zone, and large cell subtypes, and they share most of the histologic and immunophenotypic features. The large cell type has unique characteristics when it is localized on the legs. It presents in elderly patients and lacks the characteristic CD10 expression and the translocation of 14 and 18. The cause is rarely aggressive. Follicular lymphoma is the most common indolent lymphoma. It makes up about 20% of all cases of non-Hodgkin lymphoma. Follicular lymphomas typically occur in middle-aged or elderly adults. They usually present as a slow-growing, non-tender enlargement of lymph nodes, taking months to years to become clinically apparent. However, it's usually disseminated at present. More than 35% is phase 3 to 4, and more than 50% have marrow involvement. It is not curable, but has indolent cause. The median OS is more than 10 years. They tend to be resistant to curative chemotherapy, but even so, often have an indolent cause. With time, the follicular lymphomas can exhibit a change in histology and evolve to a more high-grade tumor class with a worse prognosis. About 90% patients have translocation of 14 and 18, which place proto-oncogene under the influence of the immunoglobulin heavily chain gene locus. The use of PCR or FISH technology to detect immunoglobulin gene rearrangements and the BCL2 translocation permits the detection of very small numbers of malignant cells in clinical specimens. This is pathology of follicular lymphoma. It's still a nodular pattern of growth. The presence of large cells or a mixture of diffuse and nodular architecture suggests a more aggressive variant of the disease. Once a diagnosis is made from a node or tumor mass biopsy, a search for evidence of disseminated disease should be undertaken, using studies of blood and bone marrow for cell morphology, immunophenotypic markers, and gene rearrangement. These hematologic studies will often be positive. Staging is based on clinical examination and thoracoabdominal CT imaging. Here is the GELF carrier, which can help the clinical physicians to decide whether the patient with follicular lymphoma has the indication for treatment. It is consisted of 7 factors, including lesion involvement of more than 3 nodal sites, each with a diameter more than 3 cm. Any nodal or extranodal tumor mass with a diameter of more than 7 cm. B symptoms: splenomegaly, pleural effusions, or peritoneal ascites, cytopenias, and leukemia. Follicular lymphomas are considered to be a low-grade non-Hodgkin lymphoma. However, there is a great heterogeneity in cause of individual patients. For better prognostic assessment, a follicular lymphoma FLIPI has been designed based on the following 5 features with significant prognostic impact. Age above 30 years old, Ann Arbor stage 3 or 4, elevated LDH, hemoglobin less than 12, and more than 5 nodule sites, which each feature scored as 1 when present. 0 to 1 score means low risk, 2 score means intermediate risk, more than 3 score means high risk. That's all. Thank you.